Good morning, everybody. Thank you so much for being here today. My name is Nancy Walters. I'm the Executive Director of the La Jolla Community Center, and I'm very pleased to have you join us for our Distinguished Speaker Series online version. So thank you again for being here. We're excited to have Dr. Eric David Adler, cardiologist and medical director of heart transplantation at UCSD. We also have Glen Rasmussen, who's going to be joining us to introduce Dr. Adler a little bit more formally. Glen Rasmussen is the LJCC chairman of the board and also a patient of Dr. Adler, so he'll be telling us more in a little bit. I also want to let you all know about our next Distinguished Speaker Series, which is happening, it's always the second Tuesday of the month, so it'll be next September, Tuesday the 8th, and that'll be at 10 a.m., and it'll be featuring travel writer extraordinaire David Swanson, who has a book called 100 Things to Do in San Diego Before You Die. So he'll be telling us and a little bit more about that and featuring spaces in La Jolla especially. So that'll be really wonderful to watch. And you'll all receive an invitation after this program as well. And before we get started, I also want to thank Judy White, who is the underwriter of our Distinguished Speaker Series. So thank you to her for her generous contribution. And of course, if anyone is interested in sponsoring any of our events, please make sure to get a hold of me. You can do that through our website. What you could also do on our website is check out all of our programs that we have going on daily, weekly, and monthly. We have wonderful classes that are available to you, everything from yoga, art, music appreciation, plus speaker series like today's, and so much more. So please visit our website, ljcommunitycenter.org, to learn more. So before we get started, I just want to remind you that there's a Q&A option at the bottom of your screen. Just please use that to ask any questions, and we'll get your questions answered at the end of Dr. Adler's presentation. And before we get started, and before I have Glen introduce Dr. Adler, I would just like to do a quick poll. I would just like to take a second just to have some information, just to learn a little bit about how you learned about today's event. So if you could just take a quick second to read the question, which again is, how did you hear about today's Distinguished Speaker Series? Just to let us know a little bit more about how you are learning. And we'll just give this about 15 more seconds and then we'll get started. So again, feel free to use that chat or Q&A option at the bottom of your screen to ask any questions, and we'll get to them at the end of the presentation. Wonderful. Thank you so much for your input. Now, without further ado, I'd like to introduce Glen Rasmussen, and he'll tell you a little bit more about Dr. Adler, and we'll get started. Thank you all.
Hello, everybody. Good morning. I'm Glen. I'm the chairman of the board of the La Jolla Community Center, and I'm a heart transplant patient. 13 months ago, I received the gift of life through Dr. Adler's program. I'm very fortunate. I've taken good care of myself my whole life. I never, ever thought that I would have heart problems. There was no sign of any heart problems throughout my life. The few times I've seen doctors, it was for orthopedic things. So the last thing I expected was to ever have heart problems, and it turns out I have a very rare disease. And I'm one of those people who was very surprised to find something later in life at age 69 that was potentially going to cause my demise. But being in good shape and having a rare disease, and also being so fortunate to have a good cardiologist diagnose me, I was referred to Dr. Adler's program at UCSD, and 2.5 months later, I received a heart transplant. Couldn't imagine having one, but 13 months later, I can tell you I feel fantastic. I'm out hiking around the hills in La Jolla. As soon as I can get into the water, I'm going to resume ocean swimming, and it's like it never happened. The surgery was absolutely painless. I couldn't believe that. I woke up and no pain at all, never took an opioid. Within 4 days, I was up walking around the ICU at UCSD, walking about a mile, surprising Dr. Adler, and told me it was like I had a new motor, and that's exactly right. Dr. Adler runs a program at UCSD in organ transplantation, heart transplantation, lungs, and other cardiovascular organs in Sulpizio Cardiovascular Center. There he is the head attending physician. He is also a clinical professor of medicine at University of California. He was educated at Boston University. He did his internship at the University of Washington School of Medicine, residency at the University of Washington, fellowship at Mount Sinai in New York, and was a visiting heart failure fellow at Columbia University. He holds licenses in New York, Oregon, California, Nevada, all in cardiology. His resume is huge. He's one of the top docs in the world for sure. He's invited multiple times to lecture to the medical industry. Holds major committee appointments from 2007 to 2019. Multiple offices and committee assignments in professional societies. He has trained about 10 fellows in cardiology, including several that I know and have met and have treated with at UCSD. Many books, many publications, and it's impressive. Over 50 publications. On top of that, Dr. Adler is a really nice man. He directs a program at UCSD that makes you feel like family. I have friends who are fellow heart transplant recipients, and we all feel the same way about Dr. Adler, his doctors, and his program. We're very lucky in La Jolla to have University of California at San Diego in such a distinguished, as such a distinguished school. Its survival rate for heart transplants is the highest in the country after 1 year, and I'm one of them. So I'm very grateful. I'm very pleased to introduce Dr. Eric Adler.
Thank you. Thanks very much, Glenn. Thanks for arranging this special event and for being such a great patient. And one of the best parts of our job is we, I always say we get more than we give. And sometimes that's hard for our patients to imagine, but I promise it. And it keeps us doing what we do. So we're really grateful for being able to help people like yourself and help people live with and fulfill their purpose. So thanks so much. So today I'm going to talk briefly about Glenn and about cardiac transplant in general. I'm going to show some slides now. This picture is interesting, actually. This is a picture of a patient of ours, obviously not Glenn, who was waiting for heart transplantation, and her husband was a cartoonist, and he was anxiously waiting for her to return from the operating room, and so he drew on the dry erase board where usually doctors communicate with nurses. He drew the patient, and here's the patient who's right before she's going off to heart transplant, and here am I diligently taking notes and preparing her. This is my partner, Victor Pretorius, the surgeon who does the majority of our heart transplants. And it was pretty profound to get to walk in the room in the morning awaiting the patient to return and see this masterpiece on the wall done by this patient. So I snapped a picture of it, but it captures a lot of what we do. And Glenn was singing my praises, but in fact, heart transplant is a team sport, and I would be nowhere without the team. And I'm very lucky to be on the team, and that includes Dr. Pretorius, who does the surgery. Maybe you'll be fortunate enough to have him speak as one day as well. So we're nearing 50, we're at around 52 years since the first heart transplant, nearly 53 years almost. And, you know, surprisingly, not a lot has changed in heart transplant. And I think that is testimony to the amazing innovation that is associated with transplant. And that being said, I want that to kind of provide context by explaining a case, and this is the case of Glen. And I met him actually after he had been diagnosed by a colleague of mine with atrial fibrillation about 2 years before I saw him, I believe, and had been doing okay, had these abnormal heartbeats, and no one really understood why. And he had a picture of his heart taken, and in that picture, his heart was known to be quite thick, abnormally thick, especially for an otherwise healthy patient. And he was diagnosed with cardiac amyloidosis. So he had a cardiac MRI, magnetic resonance, which is a high resolution picture of the heart. And in that picture was noted to have amyloid. And he was sent to UCSD for further evaluation. So amyloid is a rare disorder that affects the heart, the kidneys, sometimes the brain, sometimes the liver, and it requires specialized care like the care we do at UCSD. So why would we care about rare diseases? Well, I always take the time to explain why people should care about rare disease, because they say, oh, this is not affecting me, why would I care? It turns out that even though a rare disease affects less than 200,000 people, there's 7,000 rare diseases. So when you start doing the math, your chances of having a specific rare disease is unlikely, but the chance of having some kind of rare disease is common. So collectively speaking, many people are affected by rare diseases, and be affected by a rare disease like amyloid is particularly challenging because most doctors don't know what it is, don't know how to treat it. A lot of the times the patients know more than the doctor. It requires specialized care, sometimes experimental care. It's complicated. Multiple organs are usually involved in rare diseases like amyloid. It often has the incorrect diagnosis. Like in this case, it took over 2 years, I believe, before Glen's diagnosis was accurately made. And it's difficult to find specialists. So I hope everyone recognizes how lucky we are in San Diego to have an institution that basically has specialists on almost all of these rare diseases. And you know, many cities in America, you have to leave the city to get care. And in San Diego, we have this wonderful city, and in general, you don't have to leave because we've got amazing medical care right in town, cutting edge medical care. And in this case, rare diseases like amyloid are important to diagnose because they have specific therapeutic options that might be able to treat the pathophysiology. So getting to the right place when you have a disease that no one can figure out, getting the right diagnosis is critical because there are sometimes specialized medicines or therapies, or just knowing when to do surgery, when to do heart transplant, requires expertise. And that's one of the things that we offered Glen. So amyloid is a weird, rare disease. It's basically deposition of proteins that should be normally broken down. And instead of these proteins being broken down, they accumulate in all kinds of places. So as in Glen's case, they accumulate in the heart. And here's a picture of a thick, thick heart. I should have had another picture of a normal heart. But you can see here, there's barely room for blood to fill into the heart's cavity. Here's the left ventricle and the right ventricle. Here is the EKG of this patient. And this EKG, there's barely any voltage. Again, I should probably had a normal one. I apologize. But what that tells you is that this heart is thick, but there's no electricity moving through the heart in a normal conducted way. It's very low voltage. It's mostly filled with insulation, and that becomes a problem. And you can see in amyloid, we have other tissues affected. Many patients note the same deposition of protein in the tongue. And so they have thick tongues, they have trouble swallowing and speaking, and sometimes in the eyes. And so they'll get these raccoon eyes where their eyes easily bruise. Again, all typical of amyloid. And here's a heart picture where we can see this heart really being thick, affected by amyloid. And this is what was going on with Glen. Why do people get amyloidosis? They get amyloidosis due to the deposition of 3 different kinds of protein. Sometimes they get protein that's essentially made by the bone marrow, and that's a kind of a malignancy, kind of cancer. Fortunately, Glen didn't have that kind of amyloid, but that's one of the amyloids that we see. The other kind of amyloid we see is from a protein that's made in the liver called transthyretin. And that protein we're seeing more and more commonly in patients getting built up. The liver makes this protein as we age, and it gets deposited. It's usually from patients that have mutations, so they're born with a genetic error where their liver makes the wrong kind of protein. It can also be from chronic inflammatory disease like chronic bowel disease, tuberculosis, used to call amyloid, all these kind of things. They all have in common the deposition of abnormal proteins that can't be cleared. They are characteristic features. They basically glow in the dark under the right conditions. And that's how we diagnose amyloid. So you can imagine you need to have your eyes wide open and know what amyloid is. You have to know the specialized tests to do it. And that's how we diagnosed Glen. So he was started on a specific therapy to treat his amyloidosis, and that worked for a period of time, as well as water pills to help get rid of the water that was accumulated because of his stiff heart. So he had, in heart failure, we have water accumulating all over the body. But unfortunately, over a short period of time, his symptoms worsened. And in fact, Glen was having fainting, required a pacemaker, another evidence that his symptoms were worsening and worsening. And at this point, we decided to move aggressively to get him on the heart transplant list, because we knew, despite best efforts, Glen was getting worse. And this was in conjunction with my partner, Tony Ure, who's a real specialist in amyloid. And we were able to move Glen onto the list and hope that we could get him transplanted. So at this point, we're racing against the clock once we get someone on the transplant list. So where have we been, shifting gears from about amyloid and about Glen's case, more broadly about transplant. So many of you may on this conference call may recall the history of heart transplant, but it's really audacious and it's worth reviewing. And you have to put it in the context of that before the 1950s, just the concept of doing any heart surgery alone was radical. People thought if you touched the heart, it would stop working. It wasn't until real innovation, primarily started by Michael DeBakey in Texas, who, and I was fortunate enough to have dinner with him at one point about 15 years ago before he passed, who did the innovations in cardiac surgery that allowed for heart transplant to develop. In fact, this famous story is, many of you are familiar with Gore-Tex. Well, Gore-Tex was actually first used to help repair the heart and the aorta. And the reason that DeBakey used Gore-Tex and Dacron, which is a type of which is material like Gore-Tex, his wife was actually shopping at the Woolworth store where they were selling this new material to make vests and jackets. And she brought some home because she thought it might be good for surgery. And she actually sewed the aorta that ultimately was used, the first aorta. So you can imagine how it seems absurd now, but that was something they did. She helped put it together, and then he sterilized it, brought it in the OR, and they did it on a patient. So innovation looks very different now than it did in the 50s. But these kind of things were, the first heart pumps, all these things were really spurred on. The first big heart surgeries were Michael DeBakey and his predecessors in Texas. It was then in the 1960s, so after the first heart surgeries were done, it was in the 1960s that Shumway and Lauer, who moved to Stanford University to start doing the experiments to prove that heart transplant was possible. And this was audacious. And they were working for peanuts. I remind my colleagues who complain about the amount of work they do or the amount they get paid that, Lauer was working at nights and Shumway at nights using a borrowed ice cream truck to transport animals from UCSF to Stanford, where they would then do surgeries. They developed the first techniques for cryothermia, that was freezing, lowering body temperatures low enough that you could withstand the time for heart transplant. The first animal auto heart transplant, where they took a heart out of a dog and they put it back into the dog. And then they developed techniques for immunosuppression. So they really laid the groundwork for this pioneering surgery, heart transplant. They did the first baboon heart transplant. That actually, I don't know if it was done by Shumway, I forget. That was actually done by Kantowitz, I believe, but only lasted for 30 minutes. And then the first LVAD, the ventricular assist device, this is a mechanical heart pump, like an artificial heart, was all done around the same time. So lots of progress in the 60s around cardiac surgery, a lot of it coming from Stanford, a lot of it coming from Texas. But as many of you know, it wasn't until 1967 that the first heart transplant was performed, and it was actually performed by Christian Barnard in South Africa on a dentist named Louis Washansky, and he lived 18 days. You're probably asking if Shumway and DeBakey and Lauer did all this work, and I'm leaving out Kantowitz, who was also doing a lot of work on this in Maimonides Hospital in New York. How did Barnard end up doing it in South Africa? Barnard came and visited Shumway and Lauer and DeBakey and surgical greats in Minnesota, learning all of these, Lillahei, for example, in Minnesota, learning all of these procedures. And in the US at the time, there was great debate about the definition of brain death. Because to do a heart transplant, it's necessary that the transplant comes from a donor, and that donor should be brain dead. In other words, they go through some kind of catastrophic illness where their brain is no longer functioning, but their heart is still working. In the US, we still had trouble defining exactly what brain death was in a transparent and ethical way. So the society felt comfortable that you were doing a transplant and you weren't killing the person you were taking the heart from. So while we were grappling with this difficult definition and decision, Barnard got the support of the South African government, defined brain death in South Africa in a way that ultimately was adopted by and used in the US, and did the first transplant. So even though the groundwork for transplant was really laid by Shumway and Lauer and DeBakey, a lot of the credit, and some of it well-deserved, because went to Barnard. And certainly, as you know, Barnard became the celebrity well-known for heart transplantation. It was then really the modern age of transplant didn't start till the 70s and 80s. And that was because initially, even though transplant was a surgical success, the use of medication to prevent rejection, to prevent the body from attacking the heart, really doesn't develop in the 1980s, when the development of new drugs called calcineurin drugs that prevented the heart from being rejected by the immune system were developed. So it wasn't until the 80s that heart transplant, late 70s and 80s, that heart transplant really took off. And that was in conjunction also in 1982 when Jarvik, who's a bioengineer in the University of Utah, developed the total artificial heart. And that first total artificial heart continues to be modified and used today. And it's similar but somewhat improved device. At the same time, the first pediatric heart transplant started in the 1980s. So you can see the work that we did to help Glen and patients like Glen really rests on these giants who were innovators and tireless advocates for their patients. And in many ways, the innovations they did, I don't even know if they would be possible in the context of how we do modern research. The audacity that they did, and the speed, the breakneck speed in which they performed this kind of research, changed medical care forever, and I'm grateful for it. So fast forward to today, there's over 2,000 heart transplants in the United States annually. That number may be going up, and it's not necessarily good things. It has to do largely with the increase in opioid death, unfortunately. So more opioids being used, more brain dead patients, and more heart transplants. The good news is where we went from 50% of patients living a year to over 90% of our patients and around the country live greater than a year with a transplant. So that's an incredible accomplishment when you think about the complexity of heart transplant and the number of people involved and things. We're also doing more mechanical hearts, 2,500 ventricular assist devices. Those are these heart pumps that are implanted that maybe patients that have these. And then 125 total artificial hearts performed annually. So that still is low, and the total artificial hearts are still in development. So we've come a long way. Here's one of my favorite patients who's 23 years out from heart transplant. And so we've entered this third era of heart transplant, whereas the first era was simply, can we get people to survive the surgery? The second era was, can we get people to live more than 5 years? And this third era now is, can we keep people living greater than 20 years, greater than 30 years? And that's really our goal. And this is an example of my patient who's now 23 years out. I have some patients that are 30 years out from heart transplant. Really, we want this to be the gold standard. And we're learning a lot. A lot of it is learning about how to use the medications, how to detect rejection better, how to prevent the other sequelae of these medications, such as development of cancer, development of renal failure, and other complications of the anti-rejection medications. The big other problem that we faced is that we simply just don't have enough hearts for the patients that need it. The waiting list for all organs is going up, especially since 2007, when new rules for transplant centers took effect. We've modified that list since then, since the new rules, in 2018. You can see the number of people waiting for kidneys, especially in California. A patient may wait 10 years for a kidney transplant in the state of California. Liver, heart, lung, the lists keep growing and growing, and the number of available organs is limited. So this is the real crisis. This is the real challenge for us, is can we identify more donors? We do a lot at UCSD, a lot of heart transplant, and I wanted to just show this slide to remind people that heart transplant affects patients from all ages. Here are two of our younger patients who received heart transplants, and what they have done, which I think is a really beautiful thing, is they went and met relatives of their donors. So we're very grateful for this kind of work, because it reminds people and encourages people to be donors, and fill out those cards when they get their driver's license. In this case, this is one of my patients, actually the patient from the drawing that I showed in the beginning. She's meeting the sister of the donor, and she's allowing the sister of the donor to listen to her sister's heart. This other case is another one of our patients who's actually a local police officer now, who went to the wedding of this woman whose father was a donor. And so she's getting listen to her father's heart in this person. So pretty miraculous and impactful things, one patient at a time. That's the kind of work that I'm proud to be a part of. Our program in San Diego is comprehensive and offers world-class care that is the envy of, I think, of everywhere else. We do everything. We do heart transplant, heart, lung, heart, kidney, heart, liver. We have a patient who's got a heart, lung, kidney, and pancreas all transplanted. He's really running on spare parts. I tease him. We do lots of ventricular assist devices. We do all the latest technology, all done at UC San Diego. And we have patients literally coming to us from all over the United States for our outstanding care. And we have patients from Minnesota. We have had patients from Europe, small numbers of Europeans, small numbers of Middle Eastern and Asian patients as well come. We limit those numbers considerably because we want to prioritize patients from the local community. They come to the UC San Diego Cardiovascular Center, which is a state-of-the-art institution. It's small. It's only got 55 beds, so it's smaller than a lot of hospitals, but it is cutting-edge, state-of-the-art. We do some of the bread and butter normal stuff, but we really specialize in these unusual and complicated cases, complicated procedures. That's what we're really known for, including a rare procedure where we take clots out of the heart and out of the lungs, called a pulmonary thromboembectomy, arterectomy rather. We're one of the rare centers that does this in the United States. So we have patients come from all over the world for this procedure. In terms of heart transplants, we started small and continue to grow every year. And you can see the number of heart transplants since 2011 and 12, when we were doing 5 or 6 a year, has grown dramatically. 2019, we did almost 70 transplants. This year in 2020, we're doing almost greater than 50 transplants. And that's with excellent outcomes. So we've just had better and better outcomes every year as well. In fact, as Glenn was referring, we have the best outcomes in the United States when you look at survival. So the lower you are on this curve, the better. And here, this is UCSD. So we were, in both 2019 to 2020, had the #1 ranking in the US in terms of 1-year survival after heart transplant. And we're really proud of that, far better than the rest of the United States. So that's why we have patients come here, and that's why we're lucky to be here. And this was covered in the newspaper about a year ago. That's my partner and I. And we were joking around. We don't have the best baseball team, though. Our team is doing better this year. We don't have the best. We don't even have a football team, but we can be proud that the city of San Diego has the best heart transplant program in the United States. We also have a group of half the patients, our patients that tell us that satisfied with our care, and as Glenn, we have a lot of happy customers that really become part of our family. And so who's anyone, and Glenn has been to our Christmas party where we see all our transplant and ventricular assist device patients coming together, and you can see the impact we've had, and it's a really, really profound, beautiful thing. And I just am lucky every day to be engaged in such a wonderful process and impactful on people from all walks of life and backgrounds, socioeconomic status, all kinds of different things, different diseases, but they share in common having gone through this incredible procedure and thriving and helping each other. So it's an incredible group of people that our transplant patients have helped each other. One of our patients was particularly grateful, and her husband got a heart transplant, and she tattooed Dr. Pretorius's signature on the back of her back there to show her gratuity. So we're really lucky that was funny. So lots of grateful patients out there expressing their gratuity in different ways. We are looking at new ways to even do more heart transplant. This is called a donor after cardiac death. So these are patients whose hearts were not that good, and we actually put them in a machine and recover the hearts. So this is one technique that we do to improve the number of hearts that are available for our patients. We also have done audacious things. This is a heart that actually we used that had been in 3 people. This person's son died tragically and donated his heart to this woman's husband. He ultimately, unfortunately, died from a stroke and donated his heart to this gentleman who's still doing well and alive. So this donor, Mark Gerard, his heart has now been in 3 people. That's an incredibly rare feat, and that was done at UCSD, and that heart is still growing strong. And this young man is able to raise his family and his young son because of this gift of life that has now gone through three hearts. So incredible thing to bear witness to and be part of. We do a multi-organ, so we did the first heart liver transplant in the city of San Diego. And this is our patient who said, I want to thank everyone from the bottom of my new heart and liver, and he's doing amazingly well. This is him after waiting 70 days, and then this is him nearly a year later after his heart and liver transplant. So what about Glen? Well, I think Glen's story, he's told it well. He received his cardiac transplant. He's had an uncomplicated hospital course, and he's thriving. No evidence of recurrent amyloidosis, no rejection, and I think good things are coming. So we're really excited to see Glen and how he's doing, and grateful for him being able to continue to do the amazing work that he's doing. You can see that this is a process, and it's a complicated process because we realize just fixing the heart is not enough. And so this is a guidance statement that we wrote, a white paper, saying that we have to look holistically beyond the patient and look, if this is the SS heart failure boat, and I like this drawing because you can see that we are fixing the heart and all the different thongs, the elements of broken hearts, but we also are thinking about other diseases that patients have, psychosocial factors that may play into this. How is the well-being of their family members? What is their economic situation? All these things come together to make sure that they can thrive after heart transplant. And we've seen it all. We've really seen it all here. And we help people, we try to look at people holistically and beyond just their heart problems, and that's critical for success. And so we look at all these different elements when people need to get heart transplant, not just the medical elements, but do they have concomitant psychiatric disease? Are they good about taking their medicines? They have history of substance abuse. Do they have enough social support? Because transplant is something that requires a village and families to help the patient. So we work in a multidisciplinary format. We have a team of more than 50 people that help with heart transplants. So we're really grateful for that whole team. We also offer these mechanical hearts. As I mentioned, this is called a ventricular assist device. And we go through a careful process for those patients as well to determine if ventricular assist device is the right thing. And I remind patients there's no refunds once you get one of these, whether it's a transplant or bad. And we try to go through all of that in a careful way with our patients. We also tell, we want patients to know they don't have to get anything, and that they may just want to pursue palliative care and hospice care. And this is a patient who literally wanted to remind his doctors he did not want CPR, and he wrote, he tattooed, do not resuscitate on his chest. So not everyone wants a heart transplant, and it's not for everyone. Not everyone wants a mechanical heart. And so we listen to people, but everyone does deserve, we're all gonna die, whether we like it or not, but everyone deserves a death with dignity and to be without suffering. And so that's a lot of what we do as well. This is just part of our team here celebrating. And you can see we're a big team out here, and I just wanted to give credit to the entire team here. Here's some of our other patients. Here's some of the patients who brought us tacos the other day. Some of our older patients with mechanical hearts. So you can see we're helping patients well into their 80s with all kinds of different therapies. And here's some members of our team. So, I wanted to end just the last 5 minutes or so talking. Oh, here's some of our patients, I'm sorry, with mechanical hearts as well. These are patients that have had 2 mechanical hearts. And are doing well. So I want to end here, and I think it's appropriate. I know this is on people's minds, so I wanted to talk a little bit about COVID at the end because I know everyone's thinking about it. So I discussed our program and our approach and how successful we are, and then out of nowhere, COVID struck the United States and actually the world. And so how does COVID influence what we're doing in San Diego? Because it has to be, everything we do has to be put in the context of COVID now. And for me, there's the COVID, the awareness of COVID really started with friends in Italy who I got this text. This was in early March, late February, and it said, I said, be prepared, have a plan B. This came at me at 2 in the morning, late in February, from a friend in Italy who said, you know, buy food, find a place to live. And I was like, what is this person talking about? And it was COVID. And so that's how we first knew. And we were lucky, we were kind of tipped off to COVID at UCSD maybe several weeks before other people were taking it seriously. And because of that, we were able to get the right equipment, get our transplant program in order, come up with a real plan. And that was very helpful. And so we continue to do heart transplant during COVID because we're careful and smart about it. And we've actually done more heart transplants than anywhere in the United States, as far as we know, since COVID, because we've been able to set up a unit that's COVID free. We've set up our doctors in a way that we're not all working at the same time, so we can make sure we don't give COVID to each other, frankly. Do a lot of remote meetings, doing most of our visits with patients virtually. And for better or worse, patients can't see visitors, which has been very hard, but that's part of what we do as well to prevent transmission of COVID. We do daily leadership huddles. We're doing rapid testing on all donors and all recipients to make sure no one has COVID. And we haven't changed our medications all that much. We have a daily, just so you know, because I show this because a lot of people are afraid to go to the hospital. I can tell you, we're having a lot of people who are afraid of the hospital, coming to the hospital, who are having other things, that are having heart attacks and strokes, who should have come, and they're afraid of COVID. But in reality, we're doing a lot tracking. We have daily tracker boards, daily huddles. This is a live board that we keep up, that we can look at all the time to see exactly the state of COVID in the hospital anytime. And by doing this and by being smart, we're able to continue regular operations, transplants, all kinds of things. So if you're having other problems, don't be afraid to go to the hospital. We're doing our best, and we've actually had very little or almost no transmission of COVID within the hospital. And that's because we're keeping close tracks of it. So I would encourage you to seek medical care if you need it, because we're seeing a lot of problems in people being afraid to go to the hospital. And we've done over 23 transplants now since March, when we first realized COVID was on our shores. And we did have one patient die that had an artificial heart, but everyone else is, we actually had one transplant patient die as well, but everyone else is doing pretty well. So that's our story. This is another picture of our team, more members. I'm really thankful for Glen for setting this up. I hope you recognize the incredible team that we have here, and the incredible things we're doing. And I'm happy to take a couple questions if there's some questions. And thanks for listening.
Thank you so much, Dr. Adler. It's really incredible to see how far medicine has come, and of course, we are so grateful for the work that you do. We definitely have a few questions, so if I can ask one from one of the attendees. She asks, or she or he asks, how many people on a yearly basis in the U.S. require a transplant versus those who die waiting for a donor?
Yeah, that's an excellent question. As I said, we do around 2,000 heart transplants a year, and thankfully now, I would say for heart transplant, I would say the majority of patients either get the heart or get mechanical hearts, which keep them alive until their hearts become available. So that may be 70%, but we do still have high rates of death on the donors waiting for hearts. And we have less death on the wait list here at UC San Diego than many places, but it's still a problem, and that's why we need more people on the wait list, and we need to innovate our way out of this problem, whether it's mechanical hearts, developing new regenerative therapies, etc.
Great, thank you. A question from Dr. Barry Fairley asks, please tell us something about the extraordinary history of ECMO, including its use as a bridge to transplant.
Sure. So ECMO, or ECMO, as you were saying, is corporal membrane oxygenation. And that is a therapy that unfortunately we're using more and in the era of COVID. But that's a machine that provides the work of the heart and the lungs. So it oxygenates the blood through a membrane, and can be used to keep people alive for a long period of time. It's pretty dangerous. There's risk of blood clots and bleeding, and it requires significant procedure to put it in. The history of it goes back to the 60s and 70s to the first heart pumps were actually developed in Minnesota by Lillehei, then used and optimized by Kantowitz, and as who I mentioned in the rotary pump in New York. And we're using more and more ECMO, both for people waiting for heart transplant, people waiting for lung transplant, and in the era of COVID, we're using ECMO to keep people alive while their lungs heal from COVID. We even have a few patients in the US that are on ECMO whose lungs haven't healed from COVID, who are getting lung transplant.
Great, thank you. Another question from Barbara says, is there a blood test that individuals can take that might show proteins prior to exhibiting symptoms, a marker prior to symptoms, perhaps already addressed?
There are some blood tests that we can do to detect, if you're referring to amyloid. It's uncommon enough that I wouldn't do it as a screening test on everybody, because you'll have false tests, so tests that look positive that are negative. But in the right patients with the right symptoms, there are some blood tests, and as Glenn went through, there's some special imaging tests that we can do that can detect amyloid, and that's true of heart failure too in general. That can detect heart failure. There's better genetic testing that we do also that can help us figure out which patients are at risk.
Thank you. David Marsh asks, what other therapies are available now for amyloidosis? Are they discussed at the multidisciplinary monthly? I'm sorry, this is a long question. Amyloidosis conference. What percentage of patients with amyloidosis have it of the heart? Sorry,
well, that's a good question. So there are 3 new medications for amyloid. They need to be started earlier in the disease, so that's why recognition of amyloid is really important. And we do discuss these at a multidisciplinary monthly conference where we talk about patients with amyloid, whether they should get, and UCSD, we're lucky. We actually have these drugs available, and we even have the newest drugs available that are through clinical trials. They're only available at select sites. We actually have access to those at UCSD because we're recognized as a center of excellence for amyloid. In terms of what percentage of patients with amyloid have amyloidosis of the heart, there's different kinds of amyloid, and it really depends on the kind of amyloid. There's some amyloid that just affect the nerves mostly, so people will have carpal tunnel syndrome before they have any heart involvement whatsoever. And there are other mutations where it might be 70 or 80% of patients have affected of the heart. So it varies considerably.
Thank you. Now there's a question for Glenn, and I'm not sure if he'll be able to answer. So I'm going to do the allow talk function for Glenn. Glenn, the question is, what was the greatest obstacle that you had to overcome in your process of receiving a new heart?
Can you hear me?
Yes.
Oh, I think just getting my head wrapped around it. Like I said, I had no clue that I was ever going to have any heart problems. I was sailing along, low cholesterol, no congestive heart failure at all, and feeling really good. As a matter of fact, I felt really good before my heart transplant. And Dr. Yuri on Dr. Adler's team, told me that, you really need this, and that my own self-doubt about getting a heart transplant And the support I got from my family was huge because the consequences were so dire. I mean, by the time you get diagnosed with cardiac amyloidosis, I think the average lifespan is about 2 years. So just getting my head wrapped around that and the support of my family was the main thing. I remember the day I got the call, I was out walking my dog at 5 o'clock at night and my cell phone rings and it's UCSD. It's sort of like, why is UCSD calling me at 5 o'clock on a Friday? And the lady said, well, we have a heart for you. And it was at that moment that it struck me. And, you know, the next morning I was there receiving a heart. So it was all very, very, I didn't know what to expect. I didn't know how to respond. I just went with it and trusted my family, and I trusted Dr. Adler and his team. And I'm very fortunate it turned out so well.
Great. Thank you so much, Glenn. There's one more question for Dr. Adler, and it's, do you think the decrease in sirtuin enzyme activity with age leads to heart failure?
I don't think it's a principal cause of heart failure, but it's something that's really being explored, but I would just leave it at that. So I think the common causes of heart failure, or the most common cause in the United States, is coronary artery disease. So patients having heart attacks, and because cholesterol is building up in the arteries of the heart. So I encourage my patients to eat a heart healthy diet in moderation, to try to do daily exercise, to control their blood pressure, which is another common cause of heart failure. And also the same things will help ward off cancer, ward off stroke. So I think living a healthy lifestyle is the critical element. There's obviously some other potential mechanisms, including sertraline, but I would focus on heart healthy lifestyle. And I think the American Heart Association is a great resource for reading more about what that consists of.
Thank you. One more question says, can children receive heart transplants as well?
Yeah, you know, even up from newborns on, it's challenging because there's not as many donors for children. So that's been some of the hardest work that I've had, is trying to help get, and Rady's here in San Diego does transplant in children, and we do some transplant in children at UC San Diego as well, in 14 and older. But it's hard. It's harder because there's not as many donors.
All right. Well, sorry to end it on a sadder note on that topic, but Dr. Adler, thank you so much for being here and for telling us
for
about
having me.
The very important work that you do, and for, of course, helping one of our very special members of the community center, Glen Rasmussen. So thank you again for being here. Thank you all for joining us, and we hope to see you all soon. Stay well and stay safe.
Bye, guys. Be safe.
Bye.